Fordham UN intern presentation at CSW 70. We're so pleased to be doing a virtual parallel event for this 2 week conference. We've usually participated. This is a particularly exciting program that we've put together, and very soon you'll be meeting people who will be presenting at our conference. Um, you'll meet our Fordham students, and in fact, you'll meet Elena Solar, who is like the head and has organized this event. But also, you'll meet our other presenters. You'll meet Anish Nair. You'll meet Maria Trelawney Perlette. You'll meet Misha Kogel. You'll meet Monica Mendez. And then you'll meet our Australian colleagues. We've partnered with a medical school, Notre Dame, in Sydney, Australia, for many years. I think about 23 years now, and we always put on this conference with them. So our social work students will be speaking, but also our medical students will be joining and speaking at this conference. So it'll be a very interesting program, and you'll hear from a lot of different voices, and on this a very important theme. We're very concerned about health issues, for women, and so you'll learn a lot. And after this conference, this is maybe the first time some of us are meeting, but hopefully not the last. So please keep in touch. Keep in touch with us. Keep in touch with any of the speakers that you hear from, or if you have any trouble reaching someone, please contact me. I'm congress@fordham.edu. But I'm so glad you could join us, and I look forward to working with you. So now let me turn the program over to, I think, Anisha, you're going to be, no, Misha, you're going to be introducing Alina.
Yes. Thank you so much, Dr. Congress, for starting us off. And Elena Soler is an MSW candidate at Fordham University's Graduate School of Social Service and an UN NGO social work intern. In this role, she supports committee initiatives and leads social media and communications for the Fordham GSS UN student interns. She earned her BSW from the Silberman School of Social Work at Hunter College, where she worked as a research assistant and co-authored a peer-reviewed article in Advances in Social Work. She previously interned at an after-school program supporting youth development and educational access for middle and high school students. Through her work, Elena is committed to keeping human voices at the center of systems level work.
Hi, everybody. I'm so excited to be here. I'm so happy how this event came together. I'm truly honored and just grateful for my team at Fordham, especially my fellow interns, because I know that I like coordinated the program, but it would be nothing without the people I have every day by my side, supporting and like showing up to meetings. And so we've just been working all semester on this project so far, and so I'm so happy it's finally come together. I want to give a very special thank you also to Dr. Congress and our guest speakers, because this program wouldn't be without you guys and the support that you guys give us, and just taking the time to come and joining us today, as well as, of course, everybody that registered for the event and is here to support us and is willing to join this conversation because I find it so important. And I do feel just the state of the world that we're in, no matter what country or time zone you're joining us from, women's health is being challenged. And so it makes a conversation like this so critical and important to have right now. And not to mention that it's Women's History Month as it is March. So it's the perfect time to have this conversation. Women's health isn't just a woman's issue. It's not an individual issue. It affects families, communities, societies all over the world. So it makes it an issue that affects everybody, not just us. And so now I will pass it on to the speakers that will help you through this event.
We will now hear from Anusha Nair. Anusha is a generalist year MSW student at Fordham University, and she holds a bachelor's degree in criminal justice from John Jay College. Anusha has explored her passion in social services by working with older adults that struggle with mental and or physical impairments as part of the Adult Protective Services Program. She has also previously worked in an intake role for a nonprofit organization that investigates housing discrimination. Anusha is currently a social work intern supporting high school students at a charter school.
Thank you, Maisha, for the introduction. So let's get down to it. Let's frame the issue. Human rights are women's rights, and women's rights are human rights, was famously quoted by former First Lady Hillary Clinton during the Fourth World Conference on Women in 1995. It has now been 30 years since the statement echoed around the world, but women continue to experience various barriers regarding their health care. The Commission on the Status of Women emphasizes that addressing structural barriers and advocating for anti-discriminatory policies are instrumental in bringing access to services for a diverse population of women. In this presentation, we're going to provide insight into key issues, including medical gaslighting, maternal mortality among Black women, postpartum health and continuity of care, menopause stigma and health equity, and international health perspectives. As a society, having open conversations is the first step in raising awareness about issues and bringing solutions that foster meaningful change.
Thank you, Anusha, for providing such a clear and detailed framing of the issue, such a well-structured overview. Now we will hear from Maria Taloni-Perlette. Maria holds dual bachelor's degrees in biology and psychology with a minor in evolutionary studies from SUNY New Paltz. Currently, she's pursuing her master's of social work degree at Fordham University. Maria is completing her specialist internship with the United Nations, where she serves as the International Federation of Social Workers student representative. Driven by a deep commitment to social justice, Maria is passionate about advocating for systemic change and empowering marginalized communities. After graduation, she aims to pursue a career in local or international government, focusing on policy development and reform that advances equity and human rights.
From patient to policy advocate, confronting medical gaslighting in women's health. Good morning and good afternoon, everyone, and thank you for being here. Today, I want to talk about medical gaslighting in women's health, not just as a concept, but as something that has shaped my own journey from patient to policy advocate. Medical gaslighting is often discussed as personal experience, but is actually rooted in structural issues within the healthcare systems, medical training, and policy. My goal today is to connect lived experience with systemic change and to explain why this issue belongs in policy conversations about health equity and gender justice. I'm a macro social work student and advocate. I'm also a woman living with an invisible illness. For years, I experienced severe symptoms that disrupted my daily life. However, instead of medical investigation, I was often told the symptoms were stress, hormones, or anxiety, or that they were simply normal for women. It was not until my mid-30s that I was finally diagnosed with endometriosis after many years of trying to explain how these symptoms affected my life. The key point is that my story is not rare. When dismissal becomes patterned across many patients, it is no longer personal, it becomes systemic. This is why invisibility combined with disability becomes a structural inequality issue, not just an individual healthcare experience. Medical gaslighting occurs when patients' symptoms are minimized, dismissed, or attributed to emotional causes instead of being medically investigated. Patients may express concern about pain, fatigue, or other symptoms, but those concerns are not taken seriously or are explained away without proper evaluation. What makes medical gaslighting particularly harmful is that it is often subtle. It may appear as reassurance, quick dismissal, or assumptions about emotional causes. However, even subtle dismissal can have serious consequences, especially when it leads to delayed diagnoses and untreated conditions. Invisible illnesses create unique challenges within the healthcare systems. Symptoms are often minimized or dismissed or attributed to emotional factors rather than investigated medically. Someone living with an invisible illness may appear perfectly healthy on the outside. They may still show up professionally, attend school, or manage daily responsibilities, but the pain, fatigue, and neurological symptoms remain unseen. Because these illnesses are not always visibly apparent, patients often feel they must constantly prove they are sick enough to deserve care, which creates an exhausting cycle of self-advocacy. These consequences of medical gaslighting extend far beyond frustration. When symptoms are dismissed, diagnoses can be delayed for years. During this time, conditions may worsen while patients are told to simply wait and see. Referrals to specialists may be postponed, and treatment may not begin until the disease has progressed. These experiences also place strain on mental health, creating feelings of anxiety, self-doubt, and frustration. There are also economic consequences, including missed work, treatment costs, and long-term medical expenses. When disbelief delays diagnosis, it becomes a health equity issue. It is important to note that medical gaslighting is not limited to male physicians. Female physicians can participate in this as well. This happens because providers are trained within a medical system that historically is centered around male bodies as the biological norm. Many women's pain conditions remain under-researched, and diagnostic models often prioritize measurable test results over patient narratives. Healthcare systems also reward efficacy and rapid decision-making, which can reduce time spent listening to patients. So this is not about blaming individuals. It is about reforming training systems and healthcare structures. This challenge is not limited to the United States. Across many countries, gender differences in disease presentation are still underemphasized in medical education. Bias around chronic pain persists internationally, and women often report needing to advocate more forcefully in order to be believed. Because of this, medical gaslighting should be understood as a global health equity issue, affecting patients across healthcare systems worldwide. Medical gaslighting becomes even more harmful when combined with policy barriers. Insurance systems may restrict coverage for women's health services or determine that treatments are not medically necessary. Patients can face medication denial, step therapy requirements, and restrictions on specialist access. For someone managing a chronic condition like endometriosis, this can create significant uncertainty and financial stress. As a result, conditions like endometriosis often remain underfunded, contested, and diagnosed late within healthcare systems. Policy instability further complicates access to care. In recent years, both the United States and globally, we have seen reduced reproductive health protections, increasing state-level variability, and ongoing coverage uncertainty. These shifts can lead to interrupted care, hesitation among providers, and growing geographic inequality in healthcare access. Health rights should not depend on geography or political cycles. When healthcare bias persists, the consequences extend far beyond clinical settings. It can affect workplace participation, economic stability, mental health, and family systems. These impacts also intersect with broader structural inequalities, such as poverty, race, disability, immigration status, rural access to care, and sexual orientation. For many women with invisible illnesses, these intersecting barriers make accessing healthcare even more challenging. Addressing medical gaslighting requires structural change. Innovation for gender equality in healthcare must include improved training for healthcare providers on gender differences in disease, insurance reform to improve access to specialists and treatment, greater recognition of invisible illnesses, and valuing women's lived experiences as legitimate clinical information. When women are not believed, justice in healthcare is delayed. Listening is not just empathy, it is a form of healthcare. Thank you for your time and for engaging in this conversation. I hope this discussion highlights how personal experiences can inform policy change and why creating healthcare systems where patients are heard, believed, and treated equitably is so important.
Jemima is a third-year medical student at the University of Notre Dame, Australia. She holds a Bachelor of Biomedicine and a Bachelor of Science from the University of Melbourne and is concurrently completing her Master of Public Health. Through her academic training, she has developed a strong interest in women's reproductive and sexual health, with aspirations to integrate clinical medicine and public health in her future career. Jemima also volunteers with Four Voices, an organization supporting women and children experiencing domestic violence. Sophie is a third-year medical student at the University of Notre Dame. She has a Bachelor of Public Health from the University of California. She has held clinical and research roles at Stanford University and UC Berkeley, focusing on improving health outcomes through evidence-based practice. As captain of the California varsity rowing team, she promoted women's participation in athletics and founded Student Athletes Against Sexual Harassment and Assault, leading initiatives addressing gender equity and violence. Sophie aims to combine her experiences in public health, clinical medicine, and advocacy to advance health equity and empower women and children.
Hi, thank you for that introduction, Anusha. I'm Jemima and this is Sophie, and today we'll be speaking on the right to a healthy environment, climate change and the effects on women's and girls' health. In 2022, the UN General Assembly established that the right to a clean, healthy, and sustainable environment is a universal human right. This was a landmark decision that was voted in unanimously by 161 member states. This builds on decades of discourse regarding the health impacts of climate change, dating back to the 1972 Stockholm Declaration on the Human Environment, and contributes to a more cohesive standpoint on the issue. This right contains at least 6 substantive elements that governments must respect, protect, and promote. These are the right to a safe climate, healthy ecosystems and biodiversity, clean air, safe and sufficient water, sustainable food, and a non-toxic environment, alongside the rights to access to information, ability to participate in decision-making, and access to justice. Climate change is a significant threat to many's right to a healthy environment. The World Health Organization projects that between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from malnutrition, malaria, diarrhea, and heat stress alone. In 2021, over 38 million people were newly displaced by climate-related disasters, destroying their access to adequate housing, education, health, and security. Globally, in 2024, data from the Climate Action Tracker demonstrated that the worst contributors to greenhouse gas emissions per capita were Saudi Arabia, Australia, the US, and Canada, producing around 20 tons of carbon dioxide per person per year. By contrast, countries such as Chad, Somalia, Syria, and the Democratic Republic of Congo are ranked as the most vulnerable to climate change. However, these countries comparably produce just 1/10 of the emissions per capita, but unfortunately will endure the devastating effects of this output. The effects of climate change, unfortunately, are not gender neutral. 4 out of 5 people displaced by climate impacts are women and girls. When extreme weather disasters occur, women and children are 14 times more likely to die than men due to their limited access to information and resources. Additionally, the WHO and UNICEF have stated that climate-related child deaths could rise by 200,000 per year by 2030. During periods of natural disasters, there are increased rates of sexual violence, human trafficking, and child marriage, with a study finding a 28% increase in femicide during heat waves. Moreover, the Spotlight Initiative suggests that for every 1 degree of warming, there will be a 4.7% increase in intimate partner violence. Additionally, exposure to heat during pregnancy is correlated with not only the risk of preterm birth, stillbirth, and low birth weight, but places the mother at risk of gestational diabetes, preeclampsia, and heat stroke. Higher temperatures and increased rainfall expand the transmission of vector-borne viruses, such as malaria, dengue, and Zika, which pose serious risks of miscarriage, maternal mortality, and neonatal death. In climate vulnerable countries, 7 out of 10 women and girls bear the burden of water collection, and therefore, during droughts and heat waves, they must intensify their labor efforts, which increases their exposure to violence and disrupts their education, leading to poorer health outcomes.
Okay, tracking progress and the gaps that remain. So in 2025, the Sustainable Development Goals report stated that the year prior was the hottest ever on record. While global disaster deaths had nearly halved, the total amount of people affected by climate disasters surged at 124 million people. This reflects a growing vulnerability and exposure, even as fewer lives are lost. Moreover, small island developing countries and landlocked developing countries suffer disaster impacts at more than 2 times the global average and endured a disproportionate amount of global disaster deaths despite representing only 12% of the population. Disaster risk reduction and early warning system strategies have been shown to help, with countries having early warning systems having up to 5 times fewer people affected. We know that women and children bear disproportionate climate burdens, yet less than 14% of the NDCs track climate impacts via sex disaggregated data, and 9% of the environmentally linked sustainable development goals have data-based sex breakdowns. This calls for improved collection around targeted needs, for example, on maternal health and gender-based violence risks, to better craft equitable policies with data disaggregation better allowing for intersectional analysis and can save lives by adapting policies precisely to improve health outcomes for women and children. So, future policy. Current global policy is shifting towards gender-responsive climate action adopted at the COP30 in Brazil in 2025. The Gender Action Plan for 2026 to 2034 is a 9-year framework to drive sustained long-term gender-responsive climate policy and action. Other initiatives like Spotlight are mainstreaming women's rights, land access, safe disaster response, and anti-violence work into climate finance and governance. At the core, these initiatives call for guaranteeing that women and girls have real access to natural resources, a seat at the table in climate leadership and decision-making, the integration of women and children into disaster recovery plans, protection of sexual health and safety and gender-based violence protection, and embedding gender and child health indicators into national climate plans and an application of an intersectional and child-centered lens into policies.
Thank you.
Thank you very much.
Helena is a third-year medical student at the University of Notre Dame. She has previously completed a Bachelor's of Animal and Veterinary Bioscience and has worked in agriculture and education for the past 10 years. Helena is passionate about advocating for improving access to education and health services for women and children, particularly girls. She hopes that her love of education, in combination with her studies in medicine, will provide a platform to address inequities at their source. Phoebe is a psychology and design graduate from the Australian National University, exploring how cognition and perception inform human-centered design. During a competitive exchange at the University of Nottingham, focusing on mind and consciousness, she refined her ability to apply psychological theory and philosophy to practical design. Her work has been recognized through selection for the ANU Design and Arts 2025 exhibition. Through Relove Australia, she helps create dignified homes for women and families in crisis and has led projects uniting artists and musicians to foster inclusive cultural experiences. Phoebe is committed to socially impactful, psychologically informed design.
Thank you so much for that
Thank
introduction.
you.
Good morning for us and good afternoon for all our friends in the US. My name's Helena.
And my name is Phoebe, and today we are talking about trend healths in the challenges of refugee and migrant women and children.
So just to start by contextualizing this issue a bit, we have over 1 billion global migrants. 122.6 million of these are forcibly displaced. Around half are women and girls, and about 40% are children under the age of 18. So it really does have such a large scope. And these women and children really are facing a profound and avoidable gap in maternal and reproductive health care. We know that displacement correlates with worse maternal outcomes, and we see this in higher rates of maternal death and morbidity. We see increased preterm births, higher stillbirth rates, increase in congenital abnormalities. And I think a statistic that is very harrowing and really encapsulates this issue is that a 15-year-old girl living in a conflict-affected country in 2023 had a 1 in 51 lifetime risk of dying from a maternal cause, compared to 1 in 593 for a girl in a stable country.
An absence of stability, community, or safety, childbirth in a refugee settlement reaps consequences for women far beyond what is just physical, and it's largely undocumented but a very persuasive reality. And the trauma which results from the forced migration accumulates and compounds across the successive stages of this displacement. We also know that the bodily trauma of displacement is not confined to the camps or to the journey, and it lingers and manifests as the enduring psychological effects of PTSD and hyperarousal. And the UNHCR reported that up to 30% of refugees experience PTSD or depression, which is 10 times higher than the general population. Children growing up in these conditions face disruptive cognitive and emotional development, fractured education, and spend these formative years under cognitive strain. Stigma, language barriers, and insecure legal status catalyze these disparities.
When we're talking about communicable diseases, it's important to highlight how serious of a threat they pose and can potentially be life-threatening to displaced women and children. Life in transit is marked by poor housing, overcrowding, inadequate hygiene, and all of these factors really dramatically increase the risk of exposure to infectious diseases. And we can see that in respiratory diseases, tuberculosis, and in the contraction of HIV/AIDS. And we know that young girls in particular are vulnerable to poor sexual and reproductive health outcomes, and this includes the contraction of HIV/AIDS. Importantly, these risks are preventable, and with adequate healthcare access and improved living conditions can be prevented. And refugee and migrant women account for about 40% of new HIV infections in Europe when we look at the migrant population, which is very significant.
And, oh, sorry.
So gender-based violence really is an invisible epidemic. Displaced girls and women face a truly devastating spectrum of violence, and this includes trafficking, forced prostitution, rape, and sexual abuse. And what's most concerning about these statistics is that it really is the tip of the iceberg. You know, we saw a 50% surge in reports of conflict-related sexual violence between 2023 and 2024. And this is just the tip of the iceberg. We know that sexual assault reports often go unreported, and 95% of these reports were women and girls. Thank you.
Thanks.
Maisha is completing her final year of the Master's in Social Work program at Fordham University and is currently an intern with the United Nations under the supervision of Dr. Congress. She holds a bachelor's degree in forensic psychology from John Jay College of Criminal Justice. Maisha is a child protective specialist with the Administration for Children's Services in New York City, bringing 6 years of experience to her work and remaining dedicated to protecting vulnerable children and empowering families to create safe, supportive environments.
Thank you again, Anusha, and good morning and good afternoon, everyone. Today, I would like us to consider how we can transform Black women's maternal health through the concepts of voices, healing, and justice. The United States maternal mortality rate far exceeds that of other high-income countries. And of the more than 3.6 million births in 2022, there were hundreds of cases of maternal mortality and thousands of cases of severe maternal morbidity. And certain racial and ethnic groups are disproportionately affected, but particularly Black women. We see that in 2023, for every 100,000 live births, 50.3 Black women experienced maternal mortality. That is 2 to 5 times higher than other races. And Black infants also had a 2.5 time higher risk of death from preterm or low birth rate. So when we hear these numbers, we have to ask, how did we get here, right? Healthcare disparities in the United States is a complex issue. It's rooted in a history of structural inequalities, such as racism, discriminatory policies, and unequal access to resources. And for our marginalized populations, it shows up across different sectors, such as maternal mortality, but also in who has access to insurance, who has preventative care, whose mental illness is misdiagnosed. I would like us to be reminded that behind these numbers, there are real people whose voices deserve to be heard. The two women who we will speak about today, they raised their voices over social media in the same week from different parts of our country. So this is Mercedes Wells, having just given birth in her car 8 minutes after being discharged from the hospital while in active labor. Ms. Wells pleaded with the staff to stay. She was not examined by a physician prior to discharge, and she experienced postpartum complications as a result. And of her experience, Ms. Wells said, "I was stripped of my dignity. As a person, I was treated less than an animal." This is Carrie Jones. Despite being scheduled for an induction, she was made to wait over 30 minutes while staff completed paperwork with her back turned to Ms. Jones. Ms. Jones gave birth just 12 minutes after finally being moved, and the infant reportedly experienced stress during the birth and had to undergo additional testing. And Ms. Jones's mother asked the staff member, "Do y'all treat all your patients like this or just the Black ones?" And given the numbers, that may be a valid question. So these experiences are what is behind those statistics. It's a visual representation. So as social workers, we can play a critical role in promoting healing from these situations. We can provide clinical support after mistreatment. We can advocate by telling their stories, organizing in the community, and we can push for actions and legislation that holds not only individuals, but institutions accountable. And what also helps in healing is justice, when there is justice. In honor of Ms. Wells, Congresswoman Robin Kelly introduced the Wells Act, and that stands for Women's Expansion for Learning and Labor Safety. And the act builds upon her previous Maternal Health Quality Improvement Act. So the aim of this Wells Act is to improve safety and accountability in obstetric, emergency, and labor and delivery discharges. The act would require a host of things, such as a clinical justification for the discharge and mandated racial bias training. So we cannot, unfortunately, always change the hearts and minds of people, but we can change laws, policies, and procedures. In closing, as we go about our work, please remember that Black women, particularly in the United States, experience the greatest burden of maternal mortality and healthcare disparity. As social work professionals, we have a duty to raise our voices for and with these women. And let's continue to educate, let's advocate, and let's confront not only for Black women, but for all of our marginalized populations. Thank you for listening for my thoughts on the matter. And we will now hear from Anais Fernandez Ferguson. Anais holds a Bachelor and Liberal Arts with a minor in psychology and a public leadership certificate from Cornell University. She is currently pursuing her master's degree in social work at Fordham University. She has over 8 years of experience working with adolescents and has also completed an internship serving geriatric populations, including individuals living with Alzheimer's disease and other cognitive impairments. Through her work across different age groups, she has developed a strong understanding of developmental and age-related challenges. Anais is passionate about macro social work with a focus on advocacy, community empowerment, and policy change to create sustainable solutions for vulnerable populations. She is dedicated to uplifting underserved communities through education, leadership, and social action.
Thank you, Maisha, for the introduction. Today, I will talk about postpartum dangers among Black women. While childbirth is usually a joyful milestone, the weeks and months after birth can be risky. Black women face higher rates of complications and deaths compared to other groups. In this presentation, I will explain why this happens, why it matters, and what can help protect mothers and save lives. Postpartum aftercare is often inadequate, and that happens because postpartum care often ends at 6 weeks, but health risks continue for up to 12 months. Many women do not get consistent follow-up for blood pressure, heart health, infections, or mental health conditions like postpartum depression and anxiety. Medicaid coverage often ends 60 days after birth, leaving many women, especially Black women, without access to care during this critical period. Without ongoing monitoring, both physical and emotional complications can be missed, increasing the risk of preventable problems. What happens after birth? Women can face severe bleeding, dangerous blood pressure spikes, infections, extreme fatigue, persistent pain, and emotional isolation. Mental health challenges such as postpartum depression or anxiety are common but often unaddressed. Without proper monitoring and support, these issues can become life-threatening or have lasting effects on mothers and families. Mental health and cardiovascular health are also closely linked in the postpartum period. Conditions like postpartum depression, anxiety, and postpartum psychosis can develop weeks or months after birth. Cardiovascular complications, including postpartum enlarged heart, blood clots, and strokes, are also a serious risk. Black women are disproportionately affected due to systemic inequities, chronic stress, and barriers to consistent care. Regular screening, follow-up appointments, and access to both mental and physical health care are also essential to reduce preventable complications. Why Black women are more at risk? Black women are more likely to rely on Medicaid, face gaps in coverage, and experience bias in healthcare settings. Chronic stress from racism, economic barriers, and social determinants of health like housing instability and transportation challenges further increase risk. And these disparities exist regardless of education or income, showing that postpartum mortality and dangers is a structural issue rather than an individual one. So addressing these inequities requires culturally competent care, policy changes, and ongoing postpartum support. Proper postpartum care should go beyond the 6-week checkup. Women need regular follow-ups to monitor physical health, blood pressure, bleeding, infections, and heart health, as well as mental health support, including screening for postpartum depression, anxiety, and other mood disorders, with access to therapy and counseling when needed. Education on warning signs like nutrition, self-care, and infant care helps mothers recover safely, like continuous insurance coverage, like extending Medicaid for a full year postpartum, also ensures access to care during this vulnerable period. Culturally competent care that listens to and validates patient concerns are also very essential, particularly for Black women. Proper postpartum care protects both physical and mental health, improves outcomes, and can prevent avoidable complications or deaths. In summary, how can lives be saved? Lives can be saved by improving postpartum care at both the healthcare and policy levels. First, extending Medicaid coverage to a full year after birth ensures that mothers continue to have access to physical and mental health care during the highest risk period. Regular follow-up visits, early screening for heart conditions and mental health disorders, and better communication between providers and patients are very essential. Healthcare systems must also address implicit bias and provide culturally competent care that listens to and respects Black women's concerns and their voices. Investing in community-based support doulas and mental health resources can further strengthen postpartum care. Postpartum dangers is largely preventable. With better policies, improved access to care, and a commitment to equity, we all can protect mothers, support families, and reduce the disparities that put Black mothers at risk. Thank you so much.
Thank you, Anais. And we will now hear from Monica Mendez. Monica is a Master of Social Work candidate at Fordham University with a multidisciplinary background in healthcare leadership and human services. She holds an MBA in Healthcare Administration and Data Analytics and an MS in Health Sciences. She is dedicated to global health systems, gender equity, and vulnerable populations. Monica aims to leverage her diplomatic commitment to advance human-centered policy solutions that protect human rights, strengthen communities, and promote international cooperation.
Thank you, Maisha. Good morning and good evening, everyone. Today, let's talk menopause, understanding the transition and ending stigma. What is menopause? A woman's body goes through several transitions during its lifetime. One of these transitions is menopause. Menopause is a biological change in the reproductive system of women, typically in their 40s and 50s. During this stage, the ovaries stop producing the hormones estrogen and progesterone, which leads to the ending of their menstrual cycle. Women can also go into early induced menopause due to health issues. Menopause is not a single moment. It is a continuous process that happens over time and in stages. This process happens in 3 stages: perimenopause, menopause, and postmenopause. The perimenopause stage is when a woman's body starts to experience the changes leading into menopause. The symptoms associated with this stage can start several years prior, in some cases occurring for some as early as their 30s. Some of the symptoms include hot flashes, mental fog, problems concentrating, fatigue, irregular menstrual cycles, and mood fluctuation. The next stage is menopause. Women are said to be in menopause after being 12 full months without a period. At this stage, the menstrual cycle has fully stopped. The third stage is postmenopause. As per the Cleveland Clinic, women stay in this stage for the rest of their lives. During this phase, many of the symptoms begin to subside. These changes are life-altering transitions that impact women's mental, physical, social, and emotional well-being. Why is it important to talk about menopause? Menopause affects millions of women across all regions and cultures. Despite this shared commonality, it remains a taboo subject and is stigmatized. This natural biological transition is viewed negatively due to various factors, one being ageism and society's obsession with youthfulness and beauty. These societal views force many women to stay quiet about the changes in their bodies, making them feel shame and a sense of worthlessness as they age. The fear of being seen as overly emotional and less competent at work further forces women to stay silent and hide their symptoms. This sense of shame discourages them from speaking freely and openly about the challenges they face during this pivotal phase. This silence prevents women from seeking support, resulting in them missing out on resources that could help manage their symptoms. It also alienates them and deprives them from forming supportive communities. Open communications about menopause require a village. Otherwise, the prolonged silence on the topic will lead to many more women to suffer in silence. Health inequality. Menopause is not only a biological transition, it is also an issue of health inequality. It is reported that 1 in 10 women are forced to leave their jobs due to menopause symptoms. Socioeconomic inequities can impact a woman's access to treatment. Women with limited finances are forced to suffer through many symptoms of menopause because they can't afford the treatments and services available for the transitions their bodies are going through. Racial and ethnic disparities are prevalent in menopause. Studies suggest that many women of color experience menopause earlier in life and that their symptoms last longer. Social determinants of health and inequities in the lives of women of color further disadvantage them in finding relief for their symptoms and prevent them from accessing the healthcare they need. Gaps within healthcare systems, such as minimal medical training, result in menopause being misdiagnosed, mistreated, and in many cases overlooked. A call to action. Education awareness is critical. An update to medical school curricula could include comprehensive menopause education and treatment. It's important if we hope to decrease misdiagnosis and provide adequate treatment options. Public campaigns that educate the public are also needed. Education can help normalize the conversation around menopause. It can also end the silent suffering many women are facing. Policy and action is necessary to support women while they go through menopause. Workplace menopause related medical leave should be implemented across industries. This would prevent many women from leaving their jobs because they will receive the necessary support. Lastly, research and data should be expanded. Longitudinal studies can help us better understand the long-term health and economic impact of menopause in the lives of women. Inclusivity in menopause research is also crucial in order to better support women of color during this life transition. Thank you.
Thank you so much to our wonderful speakers that presented their individual topics so amazing. I know this was a heavy topic, but it's near and dear to my heart, and I hope it's near and dear to everybody's here. I invite you guys to take just like a deep breath and just take everything in and then exhale it out because I know these discussions can be heavy and not always the most positive. But I think it's important to note that the discussions that we had today or the topics, while they seem individual, they are actually interconnected and reflect different patterns of dismissal, stigma, and unequal access for women's healthcare. And I believe that change really does start by listening to women, validating their experiences, and finding a way to not normalize these inequities. This might start with education within yourself, within your community, because I do feel that we might face this every day without even noticing the stigmas and the biases that appear. And so sometimes it's even stopping yourself in your own thinking and saying, wait, this doesn't feel correct, this doesn't sound correct, or it's educating somebody you know, and like this is actually what happens during menopause or medical gaslighting. And just pushing that information forward, we do carry this conversation and information forward into our communities, our work, and into rooms that decisions are made about women's healthcare. And so I hope that today is a reminder that awareness and education does matter, but how we respond and how we move forward even matters even more because that's how change ultimately happens. And so now it's tends to be my favorite part of any conference or discussion. It's going to be the Q&A. So I do invite everybody from the group, whether it's speakers or people that have joined just to observe, to drop any comments or questions into the chat. And my fellow moderator, Anusha, will do a wonderful job of helping me figuring out which questions to ask to the group. And I'm just hoping that this is a moment for us to be interactive because, like I said, we have a lot of information we just threw out there. So it would be nice if we were able to process it together. So, yeah. And Dr. Congress, I saw you have your hand up. Do you have a question or a comment for us?
I don't know my hand up, but I was thinking about a question. I'm
Mm-hmm.
interested in, we spoke a lot about, maternal mortality, with Black women and then also menopause issues. But I also wonder, since our Australian colleagues are here, and we don't speak much about, indigenous because, we have indigenous people here, but perhaps not as many as in Australia. So I just wondered if our Australian colleagues wanted to say something about maternal mortality among indigenous women.
And you guys are more than welcome to unmute or raise your hand if you'd like to
Yeah,
respond.
we do see in across Indigenous populations in Australia in general that all of their health outcomes are um, significantly worse. Just in general, Indigenous populations have about a 10-year less life expectancy than non-Indigenous Australians. And those statistics, I believe, are still, I don't know the exact statistics. I can look into it a bit more, but they are reflected in maternal outcomes, I believe, as well. I don't know if any of my other Australian colleagues had anything else that they knew about maternal outcomes in Indigenous populations to add.
Thank you very much indeed. I'll just simply add that, yes, you're absolutely correct. Those health indicators are worse across the board. There is a major program of work in Australia that's been going on for some time to close the gap in these health outcomes for all Aboriginal and Torres Strait Islander people, the gap between their health outcomes and the health outcomes for the rest of Australia. It's also for Aboriginal and Torres Strait Islander women. We see it also in indicators such as rates in cervical cancer, breast cancer. So all the common indicators of health outcomes that we use for women's health are worse for Aboriginal women, including some of the things we heard about this morning, domestic violence and general violence within community. A lot of work to be done. Our responsibility.
Yeah, thanks for sharing that. And it seems that you've developed programs to try to address it as we have here. And I think we have to focus a lot on this. And then we know we have this terrible problem, but we also need to think about what programs do we have that are trying to address this issue and how can we increase them.
Yeah. Thank you so much for your guys' insight. I find it so interesting that just we're in different countries, different societies even, and we have a similarity in this issue, whether it's Black women, whether it's Indigenous women. And it really goes down to me, how does like health in general view certain populations? And then what is the biases that lies not just within systems, but systems are built by individual people. So it's the biases within us every day walking this earth that exist that certain populations die when giving birth, when we're so-called like advanced or first world countries with like with certain types of medicine and certain levels of hospitals. And the fact that we're failing certain populations in 2026 is really sad. So I hope that we're able to work forward, truly.
May I just jump in and say that when you look across the globe, Maternal mortality is the percentage of women who are pregnant who actually die during pregnancy or the first 6 weeks. And when you look at Australian population and Australian Indigenous population, and also if you look at high income or low income countries, the majority of those countries each year are getting these numbers down. They're dropping and dropping and dropping. But in the USA, they're not dropping. And that's the thing that concerns me the most, that the trend doesn't seem to be there. And it'd be interesting to see what is it that all these other countries are doing that's improving care. And I think part of it is working out which populations in America have got the worst maternal outcomes, and do other countries specifically look at programs for this particular group. And so we certainly in Australia can't stand there and say to you, oh, look how good we are. This is how you should do it. Very wrong, because we still have got a difference in maternal mortality in our Indigenous population and our non-Indigenous population. But I think a lot more sharing needs to be done, because America's got the academic information, but something's not happening in the implementation. And I think that will come from within. It needs to be Americans looking and working out, what do we need to do to target these groups to improve their mortality. But there's every country can improve their numbers, so none of us can certainly stand there and suggest something. It does need to be an inside America finding your solutions.
Yeah. I definitely agree. I think the sharing international, where the US is right now, I sadly, not to be too negative, I don't know if we're heading in that direction, but I do agree that there does need to be some sort of sharing or looking into other countries, especially if we feel if our rates are not getting any are not getting better. And like just our health system in general, it's just failing specific populations, specifically Black women, specifically communities of color. So it becomes like, where's the disconnect? Do we not value these communities? What are we doing to further support them? I think that's really where the question lies. And it's interesting how it's not that class doesn't matter, but I remember the case of Serena Williams where she had very famous, almost anybody could recognize her, but while she was giving birth, I believe she had a blood clot, and the doctors didn't believe her or just said you're kind of like subsided her pain. And then when she really stood up for herself and they ran tests, if they didn't catch that blood clot, the baby or herself could have died. And so that goes to show how somebody that's rich and famous can walk into a very good hospital and get that type of treatment. Imagine a woman that doesn't have a partner or doesn't have that type of status in society and how they get treated walking into a hospital, you know?
I'll just follow up on what Prof. Casper has said there, and in fact, absolutely that it's infant mortality rates, which is one of the critical areas where Australia has managed to narrow the gap. We haven't completely closed the gap in infant mortality in Australia, but we have significantly narrowed the gap in infant mortality, and I think there is excellent evidence about the programs and interventions that actually help support women's health during pregnancy and support a healthier birth and a healthier child. So, as we know, that first 2,000 years in a child's life sets it up for health across its entire life. I think that also just quickly, of course, noting as we note and grieve in Australia is that the issues that we see, these socially determined impacts on people, and particularly our Aboriginal and Torres Strait Islander peoples, are set up, from the last from history, that basically the process of colonization was brutal. And so we have a long legacy of historical issues that we have to very, very slowly but consistently address with our Aboriginal and Torres Strait Islander peoples.
May I jump? Thank you. May I jump in again? Last year I was at the CSW and I was at the Medical Women's Society of Nigeria event, which were Nigerian doctors. And one of them gave an excellent presentation on what she does in the hospital to decrease maternal deaths. It was a fabulous presentation. But another Nigerian got up and said, really, if we're going to solve maternal mortality in Nigeria, we should stop looking at it as just doctors. And they would agree with everything that Lynn Madden just said, that it's the SDGs. If you really want to decrease maternal mortality and increase women's health, you've got to address education, poverty, nutrition, violence. You must address the SDGs or we are never going to improve women's health. So I just want to build on what Lynn said, that that's actually a really important thing for all of us to look at.
Yeah. Thank you so much for those insights. Again, I think it's an ongoing issue no matter where in the world, and I hope that we can just take steps forward to decreasing the amount of women that do die when they're giving birth or just have like certain complications that we feel are preventable. I did want to shift a little the conversation to something a little bit more broad. So we talked about a lot of topics today, very openly, but we wanted to know, why do these topics, now that they're being openly discussed, why do the challenges continuously persist? Talking about it in general, we talked a lot about maternal mortality, but we also talked about a lot of other issues. So why do we think that, especially in the United States, that these issues just keep being brought up and there seems to be like not a lot being done to solve it because these issues aren't new? If anybody wants to take that question.
Well, I just wanted to add that I think one thing that's really critical that I'm not sure we've touched upon yet exactly is access to health care and access to quality health care and being able to, I mean, that's such an issue in our country right now that more and more women particularly, but people, everyone is losing. They're not able to afford their health care, not able to get good health care. Hospitals are closing. Insurance is the prices are soaring. I mean, I think that's such a tremendous issue in our country, particularly our country right now, that I just think is so important.
I definitely agree. I think that especially with like insurance, it becomes so complicated. I think me as a young person, now like entering this adult world, quote unquote, if you will, like it seems like this daunting thing and people have it under control, but people actually don't have it under control. And it's like, how do you even just exist as a healthy person and get the care that you need? And it always seems to be like a fight with insurance companies, a fight with Medicaid, and it's overwhelming. If that's like that's an understatement. Overwhelming is an understatement, but it's a lot. And yeah, access to healthcare is what's stopping people from honestly being healthy. Adam, you can go ahead.
So one thing, I guess, within the structural aspect of the United States as fee-for-service, private healthcare, 50 states, 325 million people, versus no real public option, Australia having a public healthcare option, versus the US, kind of this decentralization. Come to the US, you want a pro-poor solution, don't come here. You want a very targeted intervention for a cancer treatment that is only done here, this is the place to be. But I think really the question again with more or less is what's being these, kind of bottom up, top down solutions that are really struggling. If we have our gatekeepers, the US has the American Medical Association, we have insurance companies. I guess for me, or I'm curious always, is the major players within any healthcare system or political economy like Australia. You have, sure, I've read articles about shortages of primary healthcare across the board. The US ships in primary healthcare doctors from Cuba, Brazil, and all over the world. And now I think Australia and other, countries are recognizing we're really struggling to have quality trained people providing quality, sustainable, affordable care. So I guess my wonder, or I guess where I'm curious again, is how do people in Australia kind of collectively organize around creating pro-poor policy solutions that are kind of get to carry weight that are active?
I'll just, Adam, thanks very much indeed for that. I mean, essentially, it comes down to the legislation and policies at a country level, which actually set up things like, for Australia, the approach to national preventive health priorities, then the flows of financing through that support both public health interventions, so actions and policies and interventions and strategies that operate at a population level across the country. Really, really important to keep people healthy and well, to empower people to take control of their own health. And you don't do that inside hospitals largely. You do that by having addressing what we've just heard, the social determinants, making certain that you've got good roads, that you've actually got legislation that makes certain that people aren't driving unsafe cars, that you've got measures that control pollution in your environment. These are all determined at national government level through largely legislation. And then all our countries around the world, I don't think anyone funds public health to the level that it's been demonstrated can both save money and protect health, but nevertheless, you have to ensure flows of funding into public health structures. And then the essence of a healthy society rests then in having a substantial and well-trained primary care network, which is far beyond doctors. It's a multidisciplinary endeavour. And then we all need a high quality hospital and a high quality care when we all unfortunately need to front up and have some form of hospital-based, highly technical intervention. But it all starts with government policy, I believe, Adam, and the funding of population level intervention.
Um, LJ Nunez, you can go ahead if you'd like.
Thank y'all. Good evening, everyone. My name's LJ Nunez. To answer your question in regards to like access to water, for me, like the continued reliance on water wells, for example, where I'm from Honduras, Central America. And so within Honduras right now, right, there's a direct byproduct of a history where the US like prioritized that corporate extraction and that geopolitical control over the development of like sustainable public infrastructure for the people. So, within that, like the systemic neglect that mirrors directly with one of the key topics that we were mentioning today, right? Black maternal health care. Like as Elena noted, like a Black woman's affluence cannot shield her from a medical system that refuses to acknowledge like its roots on white supremacy. And we can't move forward as long as like we keep carrying there's carelessness in regards to like that anti-oppressive and culturally responsive framework. So by like consistently centering like Eurocentrism over Afrocentrism and that collective perspective, like the US won't be able to progress and go nowhere. So thank you.
Thank you so much for your response. And I definitely agree. I think that oftentimes we, especially in the US, it's like almost putting a band-aid. They're like, oh, we'll put more money here, or we'll do this with this community. And it's like, no, but like the whole system and how the system, like brain-wise, is working, like the brain of the system, there's something wrong there. But there's no work, or I shouldn't say no work, but there's very little work in addressing the actual issue, which is it's centering. I think of like the medical model, like that is based on Western ideology. You think of Eastern medicine, that's completely disregarded, or even indigenous medicine, completely disregarded as like valid. And so it's like, why is that so? And so I like thinking like that is, oh, sorry, I get so passionate. It's like, why?
No,
That's
you
why
and I
there's no
both,
change.
Elena. You and I both.
You saw me. Like, that's why there's no change because it's
Yeah.
like there's refusal as a greater society, right? Individual communities can do it, but a refusal as a greater society to
Mm.
not even change, but adapt something new. Think, like, what if this was possible? Look at the health outcomes there. And so, if funding and policy, yes, but then it's also just like a greater change in the way we think as individuals and communities. So, yes, that one really did touch my soul.
And I
Um,
and I and I appreciate the passion, Elena. I'm gonna just say this last point. I want to give everybody else a chance,
go
but
ahead.
like I mentioned, like I'm from Honduras. I'm from Central America, and for me, like where there's life, there's also death, right? So just knowing that there's a community where there's life and where there's death. When a woman is going through postpartum, those critical, it's not just 6 weeks, right? You have your grandmother, you have your siblings, you have, extended family that are there with you, walking with you, walking alongside of you. And that postpartum care is very, very critical within my culture, within Garifuna culture. So once again, thank you.
Thank you so much. I appreciate. Let me see. Let me look at our time. So I'm going to present one more question. Let me take a look. Um, So, this one's a little bit broad too. So hopefully other people, other voices that we haven't heard from can definitely jump in. Same thing with our speakers. What is something that surprised you the most when it comes to women's health care after this presentation? Is there anything that really stuck out, or did you learn something new? And you're more than welcome to unmute, to present your answer.
Something that really stood out to me during our research for our topic was just like I guess I kind of had an awareness that there would be increased death rates, and I was thinking, more due to like communicable diseases, and that kind of made sense to me in regard to climate change. But what I found really sad but fascinating was how much the rates of violence, particularly domestic violence, went up during these times, and that's something I'd never considered before that climate change could possibly have an impact on. So yeah, as heartbreaking as it was to hear that, I guess that's just a whole new lens that I feel like I've uncovered through this research.
Thank you so much. Yeah, I honestly, building on the climate change aspect, I'm from the Bronx, and so a lot of people talk about we have a big major highway that runs like across our borough. And so communities and neighborhoods that are right next to the highway, actually the children specifically have higher rates of asthma because the air quality is just poor in those neighborhoods. And so we think of like climate change and the environment as almost abstract, but when you really look down at the health outcomes and what happens when something's going wrong physically in your environment, it really does affect individual people and communities. And so I think also your presentation did a beautiful job of just putting that in perspective, that it just doesn't happen in my own borough, it happens all over the world. So thank you guys. I was so honored to have you guys present at our conference today.
Thank
Anybody else? I know it was a lot.
I
So
would also like to share, I also enjoyed the topic on climate change and how it impacts women and also our health. But I think also in terms, as we talk about the institutions and like the hospitals, like with the way that the climate is changing right now, a lot of the question that's also coming up is like, are hospitals ready? Are they prepared to handle a lot of the challenges that the climate is going to bring? And in regards to gender-based violence, one of the question has been hospitals not having the space during a crisis to address gender-based violence, and then also the lack of data that's collected. And I think you guys touch upon that as well. The, minimal data that we have access to in order to address the issue. So I really enjoyed it. Thank you.
Thank you so much. And thank you everybody for being here and my speakers for presenting. And again, this wouldn't be anything without everybody that showed up every day, every week. And of course, the people that came and saw us present and wanted to be part of this conversation. It really honestly does mean a lot to me, especially given the state of our world, especially in the US. I think that these conversations and building community is really where we have to turn to when oftentimes, at least for me, it feels like the government is against me or against my community. It really does touch my soul. So thank you for everybody for showing up today and being willing to listen and be part of the conversation. So thank you guys so much.
Thank you so much, Elena, for putting it together. Thank you, everyone. This was wonderful to have this conversation and so necessary.